is between 6 months and 12 months. Boys are more affected than girls. 50% of children 1 year of age will have at least one episode and occurs more frequently in the colder months. So the reason why we have acute, we have noticed that sometimes in our setting, children, when they get flu and cough, they can get or they end up seeing prurient discharge in the ear. Why? Because infection ascends from the nose, the nasopharynx, through the eustachian tube, as we saw, through the eustachian tube to the middle ear. So that's why in children, when they get flu and cough, you will not be surprised that if a child coughs, they will end up having discharge in the ear. So that is because the eustachian tube in children is short. As we saw in the anatomy, it is short and it's always open. So infection can easily ascend, and early treatment of upper respiratory tract infection in children often prevents occurrence of acute otitis media. The most likely organisms, as we have strep pneumoniae, Haemophilus influenza, Moraxella catarrharis. These are the most common organisms that we find, and most of the time the antibiotics are tailored to these organisms. But other organisms can also be included, like group A beta hemolytic strep, Staphylococcus aureus, Pseudomonas aeruginosa. We have seen Pseudomonas and that gives you a greenish foul smelling discharge. Respiratory syncytial virus is also associated sometimes with acute otitis media, as we say, infection ascends. And Mycobacterium tuberculosis. This one happens more in children or patients who are immunosuppressed. In this instance, those who are HIV infected. Risk factors of acute otitis media. All acute otitis media with it, or otitis media with effusion, or chronic otitis media. We have said one is upper respiratory tract infection, adenoiditis. We know that adenoids are found in the nasopharynx, tonsillitis in the oropharynx, or coryza flu. So when you get this infection will affect the mucosa of the respiratory system, and infection will, if untreated early, the infection will ascend into the middle ear via the eustachian tube and cause otitis media. Craniofacial abnormalities such as cleft palate or Down syndrome. These ones are because in these children, they have craniofacial anomalies that affect the closure and opening of the eustachian tube. In cleft palate, you find that even regurgitation of food, all fluids through the nasopharynx is into the eustachian tube occurs because you lose the ability to close your veropharyngeal sphincter when you're swallowing. So that is it. Then passive smoking, children who are exposed to passive smoking, or in adult smokers, because they affect the mechanism of action of the cilia. So the cilia that is on the respiratory epithelium is meant to clear the infection and beat the infection or the mucus to the back of the throat. But if someone is a passive smoker, that mechanism of cilia, that convey belt is affected, and they end up having otitis media. Mechanical obstruction, anything that can obstruct the nasopharynx, like nasal polyp, all adenoid hypertrophy, all a nasopharyngeal tumor. So these ones, they end up blocking the eustachian tube, and they do not cause acute otitis media. They predispose to otitis media with effusion, because the fluid that accumulates is usually serous, disease-free, but fluid keeps on piling. Why? We saw that the eardrum, the middle ear has respiratory epithelium, but it's cuboidal, and it has some mucus cells which continue producing fluid that is cleared into the nasopharynx and you swallow it normally. So when the eustachian tube is blocked, that fluid produced in the middle ear is not drained. And so that the fluid will accumulate in the middle ear. Daycare tendency, you know, you treat this flu, she'll get from this one or he'll get from this one. The sharing, the ability, the fact that you're not spacing the children is a risk factor. So they will keep on getting recurrent upper respiratory tract infections, which will lead. Then bottle feeding. Bottle feeding, this is because children who are fed with bottles, sometimes children do not have the I am full button, and they end up filling their stomach and regurgitating. So in that process of regurgitating, sometimes they regurgitate milk into the middle ear, and that can be a source of infection. So that's why the nipple, the breast is different in such a way that even in its orientation, the sucking helps the milk to flow down. And as you know, that in children can cry and swallow at the same time. Why? Because the epiglottis is way up. Okay, we shall see all that in the anatomy, but because of that, so bottle feeding does not allow that mechanism of the eustachian tube to close properly, and that predisposes the children to infection. Immunosuppression, as we said, we have HIV, chemoradiotherapy in children, maybe who have had lymphoma and other cancers that respond to chemotherapy, and autoimmune diseases. Autoimmune diseases also may compromise someone's immunostatus. Pathogenesis, so we say it is mainly due to eustachian tube dysfunction. The eustachian tube plays the role of being a passage. Sometimes you can have outside. So you have this infection ongoing to the upper respiratory tract infect in upper tract, and then it proceeds. All otitis media starts with features of an upper respiratory infection leading to an acute otitis media. As we have seen, the disease course starts with the prodrome. The prodrome is, is the infection that is in the upper, or the inoculation, or you get the flu, or you get the COVID, or COVID doesn't go to the ear that way. But then after the inoculation of the infection through the eustachian tube into the middle ear, then you get inflammatory changes. We know there are 5 inflammatory components of the inflammation. We have redness, pain, swelling, lobar, and lubar, that is redness. We have pain, we have loss of function, we have swelling and edema, I think. So when that occurs, and exudates, as we saw. So with inflammation comes the exudates. The exudates, which continue to increase, become prurient, which is a suppurative, and then resolution, the infection being cleared by the body with the help of antibiotics and other treatments we shall see. If that doesn't happen, then you shall end up having recurrent otitis or acute otitis, chronic otitis media. So as we have seen, mucociliary defects, that is in passive smoking, then you get bacterial colonization, strep pneumoniae, bacterial adhesion, then we have alternate immunoresponse, then we have this viral infection, which is also affecting that. Then we have ascending infection, which can also start from tonsillitis or bacterial or adenoiditis. Then all these are reservoirs. So all these, they ascend through the eustachian tube to cause acute otitis media. Other pathophysiology, secretions and edema, as we have seen, components of inflammation, they can sometimes obliterate or obliterate the eustachian tube, so causing eustachian tube dysfunction, and that fluid can get infected. That fluid can get infected, and then you get acute otitis media. Or sometimes you can have Nose blowing or sniffing, which can lead to reflux of nasopharynx, the nasopharyngeal contents from through the Eustachian tube into the middle ear. Okay, this we have discussed in detail. So prodrome, we have ear fullness, the symptoms that the patient will have. In the beginning of inoculation, the patient will have ear fullness and discomfort, low-grade fevers and malaise. If you do otoscopy or an ear exam, you find that the TM is dull, TM with slight retraction, reduced or absent landmarks. The landmarks of the TM now you know. So the second phase is inflammatory. So the patient will have otalgia, fever. Oh yeah, fever is another hit, is another is the fifth component of inflammation. Headache. And when you do ear exam or otoscopy, you'll find that the TM is erythematous. In the beginning lecture, we saw a hyperemic TM, retraction, and the patient will have reduced hearing or muffled hearing. And because the Eustachian tube is involved, they'll know when you do pneumato otoscopy, you'll find the eardrum is not moving as it should. Suppurative, excessive otalgia. Sometimes this time the child will cry, because the pain is really, really extensive. And because of the bulging, the fluid has increased into the middle ear, then the patient sometimes gets a perforation of the eardrum. So sometimes when we treat early before the perforation, we can prevent it from happening. And then the last stage is resolution. So we have prodrome, which is inoculation. We have the symptoms, and we have inflammatory, which when the pain is there and you have a hyperemic TM. Then you have the suppurative, where when you look into the ear, you'll see it's bulging, and then you appreciate that you have pus in the middle ear. Sometimes if the eardrum is perforated, you'll be able to see the pus in the external auditory canal. And then you have the resolution stage. The resolution stage, we can have complete resolution of symptoms, or the symptoms can progress to chronic suppurative otitis media. So this, we can see this is a hyperemic tympanic membrane in image number 1. Then we see we have an air fluid level. This is an air bubble. Then we have a hyperemic bulging. So this is the prodrome stage. This is the inflammatory stage. This is a suppurative. You see the eardrum is intact, but you have pus in the ear. This is otitis media with effusion. This is acute otitis media. This is otitis media with effusion when you have Eustachian tube either blocked by a tumor or Eustachian tube dysfunction. Then you have fluid in the middle ear, as you see here, and then here you have air bubbles. This is chronic. We can see that this tympanic membrane is not intact. It has this perforation. This is a central perforation. You can see all the edges of the TM around it, where you also have scarring the tympanic membrane. And this is a subtotal perforation. Is involving all the pus, as you can see. Otitis media with effusion, that was for otitis, the pathogenesis of otitis, acute otitis media. For otitis media with effusion, we say we have presence of thick mucoid discharge in the middle ear. It's also known as the glue ear or middle ear with effusion. Risk factors following a viral upper respiratory tract infection, allergies, because allergies cause edema of the Eustachian tube, and that can block and fluid accumulates, or mechanical obstruction by Eustachian tube, either tumor or adenoid tissue in children. As symptoms, this patient will have, or the child will have reduced hearing. Most of the time it's conductive, and they will not have pain, but they will have tinnitus. Tinnitus is this sound that we hear in the ear in the absence of a stimuli. It can be like insects or a heartbeat. The sound that you hear in the ear in the absence of a stimulus of auditory input from the outside environment or your background is what we call tinnitus. On otoscopy, as we saw, you see a dull eardrum, and we shall have fluid in the middle ear, all air bubbles, as we have seen. Chronic otitis media, this follows poorly managed acute otitis media with a perforation. So this child is treated in the village, we don't know with what, and the patient progresses from acute to chronic otitis media. Chronic, these are people who tell you, doctor, I've had this ear discharge for years. It doesn't mean that it has been constant, but we have a latent phase in between. The mainly organisms we have Pseudomonas, Proteus, E. coli, and in our setting, sometimes we have Klebsiella. So it is Pseudomonas, Proteus, E. coli, and Klebsiella. We have two types. We have the active and the latent. The active phase, we have deep-seated ear pain or fullness and a force-mailing discharge. Otorrhea is a discharge through the perforation. The latent phase is a period where between the two active phases where the ear is dry. Acute and chronic occurs when you have acute otitis media superimposed on chronic suppurative otitis media. Most of the time is associated with complications of otitis media. So this is, as we say, this is past tensor, pars flaccida. You can see the past tensor has a perforation with eardrum scarring, and this is central perforation, but it's a large perforation. And notice that the pars flaccida is clear. So this is chronic suppurative otitis media without cholecystoma, and not the meringosclerosis. We say the eardrum is also called meringe. So this is the tympanic scarring. Okay. This is chronic suppurative otitis media with cholecystoma. Note that you have a retracted pocket in the pars flaccida with debris. So here, every time you do examination for chronic suppurative otitis media, you have to comment on the pars flaccida. We saw that the eardrum is divided into two parts. We have the pars flaccida and the pars tensor. The pars tensor has 3 layers, the pars flaccida has 2 layers. So the pars flaccida, which is above the anterior and posterior marular folds, sometimes when you have cholecystoma, because it affects the epitympanum, the upper part of the middle ear, then you have this cheesy-like discharge. And this is acute and chronic. You can see that we have signs of acute inflammation, redness, edema, loss of function, because you see this patient will have hearing loss. So that is acute on chronic. So this is the active phase of acute of chronic suppurative otitis media. Cholecystoma incisium, also known as the retraction pocket in the pars flaccida. We have presence of squamous epithelium. We said the debris is from the skin, from the mucosa from the skin that is lining the middle ear, all the mucosa of the middle ear. Squamous epithelium in the middle ear, which continually discriminates and creates a tumor-like mass. That's what we say. So you have, remember the tympanic membrane has 2 layers. You have the squamous epithelium on the outer side, and then you have the cuboidal epithelium in the inner side, which is inside in the medial side of the tympanic membrane. So the cholecystoma starts from the outer side of the tympanic membrane as a retraction pocket because the Alsatian tube is compromised. So you have a retraction pocket in the pars flaccida, and then you have this squamous cell debris, squamous that a discrimination, that undergo discrimination, and then they keep on accumulating like a tumor-like mass, and they keep on causing osteolytic changes, as we saw. Usually caused by trauma. If a patient can have an accident and the tympanic membrane pars flaccida gets retracted, we have poor healing perforation. So the perforation heals, but it inverts the squamous epithelium. So it all starts with the squamous epithelium being inverted into the middle ear where you have respiratory epithelium. Then it can be congenital So cholesteatoma can be acquired or congenital. Congenital, the child is born with this mass or eustachian tube dysfunction. As we saw, poor area. So we have it's usually benign, but it has expansive, it's an expansile destructive mass occurring mainly in the pars flaccida region due to propensity to poor aeration. As we say, the eustachian tube is compromised and then you have poor aeration, can extend, destroy the middle ear structures. As we said, it's osteolytic, it's bone eating, and mastoid system and the inner ear, which is also the vestibular system. How do we manage a child who has acute otitis media? One, prevention starts with treating upper respiratory tract infections correctly in children. So if the child has got acute otitis media, so you do otoscopy, you find a hyperemic bulging tympanic membrane, sometimes without a perforation. So without the perforation, you give antibiotics. We say the microorganisms, strep, Haemophilus, influenza. Haemophilus is common in age groups 6 months. 6 months is Haemophilus influenza. Strep in the other months, but usually in the months 6 months and below, we are dealing with Haemophilus influenza. It does not matter usually, because they all respond to penicillin. So you can choose amoxicillin in children, or because of the resistance to amoxicillin, we give amoxiclav. Amoxiclav has clavulinic acid, which is it's against beta lactamase inhibitors. Okay. So we can give penicillin. If a child is allergic to penicillin, we can go for azithromycin. If penicillin fails, you can go for cephaloxime or cephalosporins. Analgesia. So you give pain medicine because this child, as we said, in the inflammatory phase, we have otalgia. So children also feel pain. So you give analgesic, antibiotic, analgesic, and eardrop. So if the eardrum is intact, if the ear is dry, do not put an eardrop. Do not put an eardrop in a dry ear. I have seen patients come in, I put this, and this, and then you notice when you do otoscopy, the ear is dry, and dry ear should always be maintained dry. Water, nothing should enter the ear. So no use if the perforation is not there. However, we say that you need the eustachian tube the eustachian tube dysfunction is the hallmark of this infection. So what do? You give an antihistamine. In children, usually we start with chlorpheniramine. Now we have chlorpheniramine with a low dose steroid, dexafen. So we combine, we give them apidon syrup, or any syrup that you know that has chlorpheniramine for decongestion of the nose and decongestion of the eustachian tube. And also you give saline nasoresis. Your goal is to clear as much discharge around the eustachian tube as possible. So then you have surgical management. So in case you want to prevent complications from acquired otitis media, or if the child has a lot of pain, sometimes instead of letting physiology occur by eardrum rupturing, we can surgically do laryngotomy and placement of an ear tube in the suppurative phase before spontaneous rupture. So we look at the eardrum under microscope and we target this is your ambo, this is your hand of malleus, right? So here we have the cone of light. So at the level of the cone of light, that's why we put the laryngotomy. The laryngotomy will make an incision that is slightly oblique. Excuse me. No. Sorry about that. So when we make the incision, so if you don't give it time, it will close before the ear has drained completely. So what do? We put this, you see this green tube-like structure is with an empty. So this is called a ventilation tube. A ventilation tube. So all it's a T-tube. So this is an ear tube that we place into the tympanic membrane iatrogenic perforation, because we introduce it. We make it by a meningotomy, and then we put this E-tube as a ventilation tube. We do it under microscope. Then we have otitis media with effusion. This one usually we do nothing medically, however, we give supportive treatment. The supportive treatment is targeted towards helping the eustachian tube heal and open and start to resume its function of helping to drain the middle ear. So we have the supportive treatment includes antihistamines and nasal topical steroids like Avamys nasal spray or mometazone or fluticasone nasal sprays, and steam inhalation. So steam inhalation is usually recommended before the it's recommended before the steroid, because sometimes it often primes the mucosa for you to be able to, for that steroids, topical steroid. Topical steroid, it means you put it in the nose. So it's a nasal spray placed in the nose. Surgical management of eustachian tube dysfunction, we have laryngotomy and placement of the ear ventilation tubes, which we have talked about. Management of chronic otitis media, because it has been chronic, sometimes it's recommended to take a swab for culture and sensitivity. So you take off a swab using a sterile swab, and medical treatment includes oral toilet. Oral toilet is where we use a suction all an ear week to try and clean the pus out of the ear, so that you give chance for the ear for the eardrop to have contact with the mucosa. Then you give the patient a topical antibiotic. Last week we saw different ranges of antibiotic, and you also give systemic antibiotics. The systemic antibiotics recommended for acute on chronic episodes. So quinolone. I'm sorry about that. So we have quinolones. The reason why we recommend quinolones is because we saw that the microorganism most of the time is Pseudomonas, E. coli, Proteus, and Klebsiella. So sometimes, I mean, they most of the time respond to quinolones or third generation cephalosporins. Other supportive treatment in chronic otitis media, we tell the patients to keep the ears dry. So we tell them get cotton, put Vaseline, plug the ears, and then shower, and then remove them. Why? Because the eardrum is not intact. So water can also be something that is causing inoculation of infection in the middle ear. So keep the ears dry when the ears have any ear. The ears, as we saw, they clean themselves. So do not put anything in the ear. Surgical management of chronic otitis media, because we say that they have a perforation, we do what we call tympanoplasty. So tympanoplasty includes reconstruction of the middle ear ossicular chain with reconstruction of the TM. If we only want to reconstruct the TM, it's called meringoplasty. That's when you only surgically using maybe paper, cigarette paper, or using a fascia or a fat to close the the tympanic membrane perforation. However, you have to have treated this patient for 3 months. Make sure that ear has been maintained dry. Complications of acute otitis media, if it's poorly controlled, the factors influencing the spread of middle ear infection. 1, the virulence of the infecting organisms and sensitivity to the antibiotic. Sometimes you can give the antibiotic and you are not on target. So culture and sensitivity is highly recommended in chronic cases. Host resistance and immunostatus, those patients who are immune compromised, the adequacy of antibiotic therapy, and anatomical pathways and barriers to spread. So children, the anatomical barriers are not as strong as for adults. So the complications, we have intratemporal and extratemporal. The extratemporal are intracranial. So the intratemporal complications, these are complications that occur in the middle ear. We saw middle ear or inner ear or external ear. These are, we saw that the ear is found in the temporal bone. Okay, so complications include hearing loss. It can be conductive, sensory, or mixed. Acute mastoiditis, that's when inflammation spreads to the mastoid ear cells and gives you acute mastoiditis. Sometimes acute mastoiditis is associated with a subperiosteal abscess. So as you can see, this image is of a child who has a retracted inner outwards and forward with a fluctuant. This is fluctuant. You see it's shiny red, and if you test it, it will be fluctuant. This is pus within the mastoid that has created a deficiency in the mastoid bone, and it has gone into the periosteum. So this complication is subperiosteal abscess, acute mastoiditis with subperiosteal abscess. We have labyrinthitis. Labyrinthitis, that's when infection spreads to the inner ear. We have the round window and the oval window. The oval window, that's where the step piece sits. And the round window, usually it has a membrane, which we usually call the secondary eardrum. So infection can spread through that membrane to cause labyrinthitis, inflammation of the inner ear, tympanosclerosis, ear contents, petrositis, if the infection spreads the petrous apex. Here it will affect other pedals that are found in the petrous apex, and you find that some cranial nerves are involved, especially cranial nerve 6, which passes through the dodolingual canal. This then we have, it can become chronic, suppurative otitis media, so acute otitis media can become chronic. All facial nerve palsy. We saw that the facial nerve passes through the middle ear. So facial nerve palsy, the infection can spread the facial nerve. Extratemporal, we have bacterial meningitis, epidural abscess, subdural abscess, brain abscess, otitic hydrocephalus. Otitic hydrocephalus does not occur in the brain, it occurs in the part of the ear that extends, that is the fluid in the inner ear accumulates because it's usually perilymph. We say perilymph is similar to CSF. So it's usually absorbed and produced from the CSF. So sometimes when you have infection, it can be compromised, the absorption, and you end up having otitic hydrocephalus. And then lateral sinus thrombosis, infection goes and drains into the lateral sinus. Briefly, quickly, let me share, stop share. I want to share the second screen, this one. Okay, let me do share. Briefly, let's talk about share screen. Let's where we are. Oh, sorry, I need to. Let's close this one. Okay. Share screen. Briefly, Okay, share. Briefly, let's talk about labyrinthitis, and then we shall go to the question session. Objectives, we are going to define labyrinthitis, outline the types, the pathophysiology, understand the presentation, management, and outline the diagnosis and treatment. Labyrinthitis, we know the labyrinthine is housed in the temporal bone within the petrous. So the temporal bone has 4 parts. We have the tympanic, the squamous, the petrous, and the mastoid. So excuse me. The labyrinth, which is the inner ear, is housed in the petrous part of the temporal bone. It connects to the middle ear via the oval and round window. Excuse me. It connects to the CSF. Sorry, it connects to the central nervous system via the internal auditory canal. We saw that the internal auditory canal is where we have the nerves, the cranial nerve 8 and 7 exit the temporal bone to go to the brain. All them exit the cranium to go to bring nerve fibers to the face. So it connects by the internal auditory canal, which you remember, and the cochlear aqueduct. The cochlear aqueduct is an elongated tube that is extra from the cochlea that has a canal that connects the CNS, the central nervous system, to the labyrinth. So labyrinthitis is inflammation of the inner ear. It is associated with disturbance of balance, because we saw the ear is responsible for balance and hearing. So it is associated with disturbance of balance. Disturbance of balance is also called vertigo or dizziness. Vertigo is spinning sensation. You feel the world is moving around, or you are moving around. And hearing loss of varying intensity, maybe unilateral or bilateral, can affect any age, but rarely infants. And onset of symptoms might be sudden or progressive. The causes, usually it tends to be secondary to local or systemic infections. It can be a complication of meningitis, or, as we saw, a complication of acute otitis media. The organisms include, we can have viruses like Lubera, CMV, Varicella zoster, V virus. Bacteria, we can have strep pneumoniae or Haemophilus influenza. We can have autoimmune processes that end up affecting the labyrinthine. All vesicular ischemia, causing acute labyrinthine dysfunction, which can resemble labyrinthitis. So vesicular ischemia comes because the inner ear has one blood supply, and it's called the labyrinthine artery. So in a patient who has maybe high cholesterol or diabetes, they can all stroke, high blood pressure, or something that can predispose into stroke. They can also have stroke of the labyrinthine artery, which can cause this acute labyrinthine dysfunction. So the organisms may gain access to the labyrinthine through local spread, as we said, by maybe the round window, or hematological spread by the labyrinthine artery, or they can spread through congenital or acquired defects, post-trauma. Forms of labyrinthitis, we have serous, suppurative, and sclerotic. The serous or the toxic labyrinthitis usually is from bacterial toxins and inflammatory mediators, which cross the round window from the middle ear to the labyrinth. There's no direct bacterial inflammation in contamination into the labyrinth. That is the serous. Then the suppurative, there's direct contamination of labyrinth with bacteria causing inflammation and suppurative. This is more severe with systemic septicemia. And then we have sclerotic labyrinthitis or labyrinthitis ossificans. Labyrinthitis ossificans, there is deposition of bone in the fluid spaces of the inner ear. A very likely complication of poorly managed pediatric meningitis. So children who have pediatric meningitis, they have a risk of getting labyrinthitis, especially if the organism is Streptococcus pneumoniae. And if this infection is not managed adequately during the healing or the resolution phase, we have deposition of bone into the fluid spaces, into the perilymph and perilymph space. And this can cause, this can predispose the patient to hearing loss. And these children are not, we cannot do cochlear implant. Why? Because the cochlear implant needs the electrode to be placed within the perilymph cavity. Always take good and comprehensive history so that you can be able to distinguish serous from suppurative labyrinthitis. Always take good and comprehensive history, noting that all the risk factors, what key things should be noted in the patient's medical. Symptoms, we say vertigo. So vertigo, you have to ask, have a spinning sensation. When does it come? Which associated factors like movement, head position, or other characteristics? Like is it associated with nausea and vomiting? Is it associated with seeing things jumping up and down? That is oscillopsia. Then you also ask about hearing loss. So a patient will come in with vertigo, hearing loss, which can be unilateral, bilateral, profound, that they will not be able to appreciate any word said. And other ear symptoms, the patient will have oral fullness, feeling that the ear is heavy because the fluid is accumulating in the inner ear. Then tinnitus, that is the extra sound. Otorrhea, if it's associated with acute otitis media and otalgia. Nausea and vomiting, facial weakness or asymmetry if we have other complications of spatial nerve palsy. And signs of meningism like visual changes, neck stiffness, fever, headache, and ascertain if it's preceding an upper respiratory tract infection or the upper respiratory infection is present. Then we go ahead, after history, you go ahead and examine this patient. You do a complete head and neck exam, as we saw the components of the basic ENT exam are 7. We saw that in the beginning lectures. Then you go ahead and do otologic examination. Inspect for signs of mastoiditis, cellitis, trauma, or prior ear surgery. Inspect the external auditory canal for otitis externa, for discharge of vesicle. Vesicles can occur in Ramsay-Hunt syndrome. So inspect for that. Inspect the tympanic membrane and middle ear for signs of otitis media, reddening, bulging, fluid, perforation. Then do ocular examination. The ocular examination is inspect the ocular range of movement and pupillary response, and perform fundoscopy, examine to rule out papillae edema. Observe for nystagmus, abdominal eye movements that may be spontaneous or evoked on head movement. So spontaneous occur, you look at the patient and then you can see the abnormal eye movement. Head movement is when you shake the patient, you do a head shake, you move the head right to left, and then you notice the eyes and you see that the eyes can have nystagmus. Then neurological exam, you perform a complete cranial nerve exam. We saw your cranial nerve 8 can be involved, 7 can be involved, and other kind of neighboring in the petrous apex like abducens nerve. Then you also assess for balance using Romberg's test all the tandem 8. So Romberg is when you make the patient stand, they close their eyes for fixation, they put their hands, and then you see if they will maintain their balance relation to gravity. Then we have the tandem gait. Okay. Then assess for cerebellum function by performing finger to nose or heel to shin tests. Differential diagnosis, the most prominent diagnosis is vestibular neuritis. Note that vestibular neuritis is similar to labyrinthitis, but it is not associated with hearing loss. So vestibular system and cochlear system. Cochlear system is for hearing, vestibular system is for balance. So sometimes you can have vertigo without hearing loss. That is the vestibular neuritis. Differentials, you can have vertebrobasilar insufficiency causing vascular ischemia. You can have pre-syncope dizziness, like those students who stand for a long time and then they faint. You can have cerebral infarct. You can have disequilibrium of aging and drug-induced vertigo, all hearing loss. There's no specific investigation towards labyrinthitis. Therefore, good history and physical exam is key. Carry out necessary investigations to exclude other etiologies in your list. You can do a CBC, you can do TPH8, rural syphilis, you can do random blood sugar, ESR, if you suspect the patient is immunocompromised in terms of having high blood sugar. And always admit the patient and watch closely for deterioration, which can happen spontaneously and quickly, especially in patients suspected suppurative labyrinthitis. Diplopia, austral speech, gait disturbance, localized weakness, all numbness, these are danger signs why you keep the patient in hospital. Often will resolve spontaneously if it's viral in 1 to 2 weeks. Where possible, identification of the source of infection and manage. For example, if it's with meningitis, so you do an LP in case you don't have a space occupying lesion, and find the organism, do culture and sensitivity on the CSF. Antibiotic treatment depending on the likely causes and laboratory guidance. Let's say you're not able to do a lumbar puncture, but the CBC shows a high neutrophilia. So there you if you have a high neutrophilia or an elevated ESR or C-reactive protein, then you suspect a bacterial infection, and then you treat accordingly. Supportive treatment, in these cases, we give an antiemetic, steroids, bed in case we suspect vestibular neuritis, bed rest and hydration, sedatives or vestibular suppressants. So vestibular suppressants that we have on the market, we have cinnarizine and also we have beta-histidine. So you can give either at recommended doses to suppress the vestibular symptoms. And surgical treatment, in case we have very bad, a predisposing factor is acute, we can do laryngotomy to drain the external auditory, the middle ear. We can do tympanoplasty, we can do labyrinthectomy. However, these are really, really not done in our setting. Next. So complications of labyrinthitis, we have permanent damage, the vestibular system causing chronic dizziness or severe to profound hearing loss in case you get labyrinthine ossificans. So that's the end of our lectures today. We were talking about acute otitis media and acute labyrinthitis. In case we have any questions, kindly ask. Okay, any questions? What is the anatomical relationship between the inner ear and the eyes? It's not anatomical, it is functional. The vestibular system, you have input from the eye, the vertebral column, the spinal cord, and the, okay, that one we had seen in the last tutorial. Effusion. Oh yes, no, it's a beta-lactamase inhibitor, sorry. Clavulanic acid is a beta-lactamase inhibitor. So it inhibits beta-lactamase. Okay, I'm not sure. I think Christine records. Okay, any questions, please? Paddy?
Yeah, their hands being raised. So okay. I will start with Elias.
Yes, doctor. My question is about the types of acute otitis media. It was part of objectives, but didn't see it anywhere in the presentation. Thank you.
No, it's types of otitis media. Types of otitis media, and we said we have acute otitis media with effusion, and chronic suppurative otitis media. Okay, next.
Kakoza Javila, please unmute and ask your question.
Thank you, Doctor. You say the chronic media is not so poor managed media.
Yes.
Now, the organisms are quite different. Have stroke on one side and then luminous and other organisms. So why are they different? And then another question. Acute media is normally because of trauma and upper respiratory tract infection. So can you have like the ear being perforated in acute otitis externa, and then you have otitis media as a secondary infection from that?
Okay. So your first question was I didn't hear the first question. Paddy, did you get the first question?
I didn't also get it later because something about Pseudomonas.
So the microorganisms.
Yes, why do they attack? Why is it that they are this for this time and this type for, I think, for another time?
Okay, so the microorganisms in acute are usually the same microorganisms that cause that is how it has been. The second question was about, so if a patient gets acute otitis externa, infection can spread to the eardrum and cause what we call laryngitis. And we had already seen that meningitis is a form of otitis media. So it is true infection can start from the external trach canal and go to the inner ear, to the middle ear. Okay. Paddy, any other question?
Yes, we still have 2 more hands raised. Abure, unmute and ask your question.
Yes, thank you, Doctor.
Yes.
I have 2 questions. One, antibiotics only when there's suppression of the tympanic membrane. But my understanding, whenever perforation occurs, then that means there are cellular debris and there's inflammation and suppression inside. How will the topical overcome the suppression and then cause healing? I thought we would go by systemic, because there is already inflammation exudates and perforation of the tympanic membrane. How will the topical help us? Then the second question is, what are the examples of the vestibular suppressants? Thank you.
Okay, so when we have a full middle ear, it undergoes pressure because the fluid in the middle ear is under pressure, and then it will cause rupture of the eardrum, thus a perforation, spontaneous perforation in the tympanic membrane. So we give both systemic and topical. So systemic antibiotics help to clear the infection. However, the topical ear drops, they help to reduce the edema and also the microorganisms and their toxins within the mucosa directly. So we give both systemic and topical. As you saw, we give oral antibiotics and systemic antibiotics and topical. Drugs that suppress intensity of the vertigo, we have signalizin and beta-histidine. On the market, we have beta-sac. So these ones help, they're modified antihistamines that help to suppress the vestibular system. Okay.
Yes, let's Nabong, please unmute and ask your question.
Good morning, Doctor.
Good morning to you.
You had told us the 3 subtypes of otitis media. Why you named acute otitis media, otitis media with effusion, and chronic suppurative otitis media.
And meningitis. Meningitis. We had forgotten meningitis.
So where does adhesive otitis media belong?
That is glue ear, that is otitis media with effusion.
All right.
Okay. Someone said, is there a relationship between menopause and labyrinthitis? No, unless a patient has chronic comorbidities. Okay. We don't have any questions, right? Paddy, are we okay?
Yes, I think we have covered all the questions.
Okay, so your assignment for this week is to define.
Yes.
To define definition, pathophysiology, and management of. Management includes treatment and complications of subperiosteal mastoid abscess. It's a complication, as we saw, intratemporal complication of acute otitis media. Notice 7 of you, your assignments for last week were not considered because you handed in past the deadline. So the deadline is Thursday, 5 p.m. If your your work comes in after that, it will not be considered. Vestibular suppressants indicated in BPPV, no. So benign positional paroxysmal vertigo is due to otolink. due to stones in the inner ear. So usually we do what we call we do what we call the eplim. So we do the Dix-Hole Pike maneuver for diagnosis, and then we do the eplim maneuver for repositioning of the stone. You can repeat the maneuver 3 times until the vertigo has gone. Sometimes we give patients vestibular suppressants in case they had very if they had very bad vertigo and they still have residual vertigo, so you suppress the system. Okay, with a short period, like you can give a vestibular suppressant for 5 days. Pardon on the assignment, I have retyped it. Notes. But the notes do not have your assignment. So the notes are for reading and understanding, but they don't have the answers to your assignment. How do we treat a patient with cholesteatoma? A patient who has cholesteatoma, we treat them by doing mastoidectomy. So mastoidectomy is where we do, we drill the mastoid cavity and we drill, take the patient, it's done obviously under GA. We take the patient to theater and if they fulfill all the requirements for theater, and we make a post-auricular incision, and then we drill away the infected bone, we socialize the mastoid, and then we enter into the antrum and we clear all the disease from the middle ear. So that is, we call it mastoidectomy. Mastoidectomy. I've typed it, mastoidectomy. That is what we use to manage cholesteatoma. Okay. I've typed. Okay.
Doctor, please,
I beg your pardon?
Please, could you help us and tell us the assignment?
So the assignment is definition, pathophysiology, and management of subperiosteal abscess.
Okay.
Okay, just give us notes. It's our reading and understanding apparently. Okay, I should send them right now. For that topics we have covered. Okay.
Yes.
Finally, Dr. Doreen is subperiosteal abscess. It's a complication of acute otitis media, mastoiditis, acute mastoiditis with a subperiosteal. You remember we talked about acute mastoiditis. So, okay. Dr. Doreen will be with you when you come back to rotate with us. She'll take you through hearing impairment as a tutorial.
Thank you, Doctor.
Tomorrow, I mean next week, for the next following 3 weeks, you're going to have Dr. Ruth. She'll be taking you through the rhinology, anatomy, and anatomy and physiology of paranasal sinus and nose, and then takes you through acute otitis, acute rhinitis, parankylosis, septal abscess, and sinusitis with its complications. All those are 3 weeks will be taken through by Dr. Ruth. She's part of the department. Yes, management includes the treatment and complications if the treatment fails. Thank you. If we don't have any questions, let me send the work before I sign out. Thank you.